Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, Professor Emeritus of Pediatrics at the University of Arizona College of Medicine, and Medical Director of Infectious Diseases and Immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and pretty much anything else of infectious disease or infection prevention that crosses our minds. This is the week of February, 6th? So welcome to February already, everybody, and happy almost Valentine's Day. This week we have some questions which are mostly related to COVID-19 as well as respiratory viruses and a couple other thoughts that will occur to me as I go forward. The first question, of course, has to do with the newer news that on May 11th, the United States will end the public health emergency for COVID-19. And the question asks, what does this mean for COVID-19 vaccines, etc.? So I think to understand what it means, we have to understand what that declaration of a public emergency, a public health emergency means. And it meant primarily that COVID-19 tests were offered for free, that treatments such as remdesivir and Paxlovid and a couple other things, molnupiravir, were offered or covered for free. And importantly, that COVID-19 vaccines were offered for free, with the rare instances of some insurance providers charging an administration fee. Also importantly, and this is not as well known, the state of a public health emergency also meant that nobody could be disenrolled from Medicare and Medicaid coverage, which largely affected those individuals who are marginalized from healthcare or living at poverty right above or right below poverty level. So all that comes to a close on May 11th, although, as per the federal government and President Biden, the wish is not to do a sudden cease and desist on May 11th, but to gradually approach that end of public health declaration of emergency, meaning that we can anticipate both the federal government backing away, in fact, it's already been debated in the United States legislature, backing away from that mandatory inclusion in Medicare or Medicaid, and we will start to see lower income individuals potentially removed from the list of coverage, and therefore putting the burden of coverage back onto the states. Pluses and minuses, and I'm not here to comment politically what that means, but you can imagine that there are some states that wish to provide their own healthcare access and healthcare administration, while others are like, nope, that's the job of the federal government. So I think the first thing to be aware of is that we're going to see some degree of shifting in terms of insurance coverage, access in the state of Arizona, and Medicare, Medicaid coverage elsewhere in the country, in terms of who gets covered and by how much. And I think it'll really depend on how each state approaches how to pick up those individuals who have not been provided care or who will lose care by loss of federal mandated health insurance. Interestingly, that move, when it's already started to happen, has empowered the federal government to vote to support and maintain and protect, actually, funding for pediatric care of those who are not otherwise covered by private health insurance. So in a bizarre, paradoxical way, children's health up through adolescence may actually perversely somewhat more protected in terms of having health insurance benefits, vaccines, etc., and so forth. But all of this is just sort of hand-waving and predicting the future, and it truly will depend on how Arizona proceeds, and no, I don't have any insight as to how we will at this point, and also just how rapidly federal government and Medicare, Medicaid act. In terms of the other things, so COVID-19 vaccinations, treatment for COVID-19, and certainly testing, all those are going to return to a normal medical intervention, meaning that those who have private insurance or those who have some degree of Medicare or Medicaid coverage will have coverage, at least in part, for many aspects of that. I think the days of getting free test kits sent from Atlanta or from the federal government are gone or will be gone as of May 11th. And so too the ability to, after getting sick with COVID-19, just to phone a friend or phone the public health department and get Paxlovid ordered. Those will all have to be via private or personal prescription and covered to a certain extent by whatever insurance provider, if that exists, our patients have, or for ourselves as well. There is definitely some talk that some insurance providers will choose not to cover Paxlovid treatments and potentially not cover COVID vaccines as they interpret going forward the necessity of continued vaccination. Now, on the other hand, from a public health perspective, COVID-19 vaccination is likely going to fall into the same realm as annual influenza vaccine, and flu vaccines are covered, at least in part, by many insurance providers. So the hope is that that will continue to be so. But in terms of the free testing or testing for the worried well, those are absolutely predicting going to be out of pocket, and gone will be the days of going to the county health department or pop-up clinics to get tested. It'll all be, by order of a practicing physician or healthcare provider, I should say, to get those both ordered, performed, and then paid for. So it's going to be complex, folks, and I think it's very difficult to predict exactly where the balance is going to be. Clearly, those individuals who are currently without insurance coverage or who will become without health insurance coverage are going to suffer the greatest, which again brings in social determinants of health, racial and ethnicity imbalance of healthcare delivery. And I think we can expect influences and the balance of power from that are going to become even more pronounced after May 11th. And as well, the other unknown, at least for those of us living and practicing in Arizona, is how state of Arizona and Arizona Department of Health Services is going to pursue change or maintenance of current level of care after May 11th. So, fabulous question, and all I can do is sort of predict some challenges. At the very least, I think we can expect a return to more typical health insurance infrastructure in terms of what gets paid for and what does not. And it is entirely possible that we will have the joy of submitting prior authorizations for Paxlovid in the not too distant future for a patient who has mild to moderate COVID-19. So, stay tuned. We'll find out more in the not too distant future. The next question then asks about COVID-19 as an underlying cause of death among United States youths. So what we'll say, and I would even say pediatric children all the way through adolescents and young adults. So importantly, if we look at the national trend in the first 2 years of the pandemic, so March of 2020 going through actually until mid-2022, COVID-19 overall was the third leading cause of death among United States citizens. Now that's citizens, that's not including the vast number of undocumented immigrant peoples who are also sick and dying from COVID-19. But at least in terms of the recording network from CDC and the MMWR, COVID was the third leading cause of death among individuals. Heavily weighted toward adult population, and certainly a significant proportion of those were adults of age 65 and older. Importantly, pediatric death related to COVID-19 was thankfully a rare event. Now, putting that into context, Arizona at one point during the pandemic was leading the country in terms of pediatric COVID cases, and we were second, as you've heard me say in this podcast for multiple months in a row, second in the country in terms of pediatric deaths associated with or caused by COVID-19. Thankfully, though, those numbers and the incidence of those was quite low. Unfortunately, and here we sort of get into the nuances of what can be attributed to COVID-19 or not. The leading cause of death has been traumatic death, either from completed suicide or intentional or unintentional drug overdoses, and the explosion of mental health disorders and children and teenagers living with anxiety, depression, all of the suicidality and suicidal intentionality which comes with that. All those have certainly increased, absolutely related to social isolation, definitely due to COVID-19. So if I extend the question, COVID-19 as an underlying cause of death among the United States youths, if we accept COVID-19 as the trigger for increased mental health disorders, students, children, adolescents living with depression, anxiety, and suicidal ideation, then I think we can expect that there is a significant association of COVID-19 with pediatric deaths, those due to drug overdose and completed suicide. In speaking with colleagues who are in the area of mental health, healthcare delivery, either as practicing adolescent and child psychiatrists, or those who are counselors in high-risk settings, such as youth living on their own, or even high school counselors, all of them tell a grim tale of students who just almost flippantly talk about how, yeah, I considered suicide the other day, but I didn't. And so whether it's become much more overt in the conversation or whether the true incidence and prevalence of suicidality has increased, I think perhaps both are true. And it is clear that our students are living in a state of high concern for deaths by suicide and by drug overdose. So that I anticipate is going to take a while to reach a new plateau as schools and our students, our pediatric patients, continue to navigate a return to the new norm, not the old way of doing things, but the new norm in terms of where schools are at and the ability to have social interactions. My wife is a high school teacher, and she describes extensively how the students are not just feral, but they're wild. And so it's going to take more than a couple years to return to anything resembling a new state of normal as those students move past several years of lack of social engagement and perhaps learning the behavior patterns and their thought processes from social media, which I imagine most of us would agree is a dangerous thing to do. So stay tuned on that as well. The Arizona AAP chapter does track pediatric mortality with the fatality database, and we just see increasing numbers of childhood or adolescent deaths due to traumatic events, motor vehicle accidents, firearm deaths, completed suicide. I expect that'll be so next year as well, but we'll see what happens. Third question, are the respiratory viruses slowing down? And do I think there might be a return to a more normal season of infection? So the answer to the first part, yes. Respiratory virus season is definitely slowing down nationally as well as here in Arizona. RSV, rhinoenteroviruses, adenoviruses, Coxsackie viruses, influenza, all those numbers have plateaued previously and are now trending down. In many parts of the country, trending down significantly. So yay, great, wonderful, fantastic. However, we're still seeing admissions of children and adolescents with COVID-19 and other infections. We're definitely still seeing admissions for respiratory illness with some degree of respiratory failure, and including especially older children still presenting with classic bronchiolitis. It's an older age group, and they're not responding well to immediate interventions and thus requiring hospitalization on prolonged oxygen and in some cases bronchodilators for those who respond. So that is still true, and not just here in Arizona but nationally as well. Pediatric beds are still at least a 75% occupancy rate, and in some cases they're in the same situations before, like discharge patients to admit patients. And here at my local hospital, the latter is closer to the truth. There are definitely days where we have patients still rooming in the emergency department waiting for beds for hospitalization. What are we seeing that's getting hospitalized? Again, it is still respiratory illness, perhaps increasingly triggered by ebbs and flows of warm weather, so some allergens out there, and also respiratory viruses, but also seeing a significant number of students, or patients, I should say, admitted, again, for mental health concerns. So attempted suicide, drug overdose, need for inpatient observation, need for inpatient treatment. In some cases, several of the attempted suicides have been with medication, and so there's need to do detox and watch the liver. So that, to me, and this is anecdotal and based on only a little bit of data because we're very much in an incredibly dynamic phase right now, but this seems to be worse and far more bed occupancy than we are used to for a normal respiratory season. And certainly the number of beds occupied by non-respiratory diseases is higher than one might anticipate for, early February of a typical season. So again, I think that this year has still been highly unusual, and every hope is that next year will be a return to normal, whatever that looks like. At least we'll be more familiar with that, and hopefully we can benefit from lessons learned about how to increase patient throughput in the outpatient setting, how to reasonably prioritize and triage our patients in terms of advanced care, emergency department evaluation, hospitalization, etc. These are all lessons that we should have learned extensively in the past and then perfected over the last several years with COVID-19. So are we going to go back to more normal season of infection? I certainly hope so. I think so. I think we still have, this year to sort of have a washout period and then see what happens in terms of the endemicity of COVID-19 and SARS-CoV-2 in terms of how that may or may not drive isolation and masking and et cetera, and what that means for respiratory viruses. So that's it for the questions this week. One additional note just to talk about briefly, and that would be the still ongoing concern of invasive and active group A streptococcal infection. I mentioned before on the podcast, and I'll mention again, starting in the United Kingdom and then definitely seen here in the United States, a far greater than expected number of invasive severe infections with group A strep, ranging from necrotizing fasciitis from minor wounds to toxic shock-like syndrome and sepsis, and also to musculoskeletal infections. Personally, I've seen now the last 4 musculoskeletal infections, including osteomyelitis and septic arthritis, including septic arthritis of a hip, have all been due to group A strep, not Staph aureus, not Kingella, group A strep. Also, we've seen a more than expected number post-streptococcal reactive polyarthralgias. So far, not yet a post-streptococcal glomerulonephritis, but definitely have seen several cases of scarlet fever. So, if one has not seen scarlet fever or a sandpaper scarlatiniform rash in a while, keep your eyes open. There's a very good chance you will do so in the coming weeks to months or so. I mention this only to sort of continue to heighten our awareness and lower our threshold to test for group A strep, whether it's through throat culture, rapid strep, and certainly a point of care rapid strep in the office, and or if on the fence about whether to send blood cultures for a patient who starts to look as if they may be septic, err on the side of caution, because group A strep can start very mild, very much a flu-like illness, but then in a matter of hours can rapidly escalate into a full-fledged sepsis event with multi-organ failure and potentially toxic shock-like syndrome. Also, remember the buzzword, I guess, or the buzz phrase for necrotizing fasciitis. If there's a patient with a patch of cellulitis and they are experiencing pain out of proportion of the clinical appearance, meaning a lot more pain when you palpate or even touch that patch of erythema, strongly consider the potential of necrotizing fasciitis. That's a patient who would require immediate evaluation, typically by MRI of the affected part of the body, and consultation if it's a limb, an extremity, many times with orthopedics, and certainly with your local and friendly infectious disease provider, and heaven knows who else. So I think just keep the eyes open, folks. Group A strep is still out there. We're still seeing cases. And in the middle of that, we're seeing all the other stuff starting to return as well, including systemic onset juvenile idiopathic arthritis, JIA, and even a couple cases of inflammatory vasculitis and lupus. So if that is a sign of returning to normal, meaning we're starting to see a broader range of both primary infectious diseases and immune and autoimmune and rheumatologic diseases, then we're definitely returning to normal in that regard specifically. So with that, it's a shorter one, but thank you again for listening to ID Talk. Arizona members can submit questions for future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at Arizona AAP or AzAAP.org. In the meantime, and as always, keep those questions coming. Anything is on the table. Challenge me. Make me look something up. Ask unusual questions. I'll do my best to answer. Just try and keep it in the area of infectious diseases, infection prevention, and, of course, anything and everything related to COVID-19, which was the original cause for this podcast. So hang in there, folks. Keep fighting the good fight. Be nice to each other. Be nice to yourselves. And thank you all for your service.